How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, are all made of DNA. We're all made of the same chemical DNA. We're all made of DNA.
Hi, you're listening to DNA Today, a podcast and radio show where we discover new advances in the world of genetics. From genetic technology like CRISPR to rare diseases to new research, we have you covered. For a decade, DNA Today has brought you the voices of leaders in genetics. I'm Keira Deneen. I'm a certified genetic counselor and your host. Did you know PerkinElmer Genomics was one of the first laboratories to offer whole genome sequencing on a clinical basis? Whole genome sequencing can maximize clinical diagnostic yield for patients. With turnaround time of 4 weeks for the proband sample, PerkinElmer's whole genome sequencing test is designed to provide access to additional valuable information compared to an exome. PerkinElmer also offers prenatal whole genome sequencing as well as ultra-rapid whole genome sequencing for critically ill newborns using dried blood spots. The ultra-rapid genome has a turnaround time of 5 days and includes mito, chromosomal CNV analysis, STR-TNR screening, and biochemical analysis. Also, listen back to episode 176 with Dr. Madhuri Hegde, where we explored the power of whole genome sequencing, which also happens to be one of my favorite episodes of DNA Today. And stay tuned for a couple more episodes with PerkinElmer soon. Discover all that PerkinElmer Genomics has to offer at PerkinElmerGenomics.com. Joining me on this episode is Dr. Heather Cheng. She focuses on improving the care of patients with prostate and bladder cancers. As an expert in prostate cancer genetics, she is studying ways to use genetics to guide care of prostate cancer patients and their family members who may be at high risk also for the disease. So thank you so much for joining me on the show, Heather.
It's a pleasure to be here today with you, the audience.
So we're jumping into cancer, which we should do more on this show. I think listeners need to hold me to that. I think I get into my prenatal realm and rare diseases, but cancer is such an interesting area, and so much is exploding with this in terms of everything that we're learning. So I wanted to start out and frame our conversation by defining how common prostate cancer is, because I think most people know someone either in their family or a close family friend that's had prostate cancer before. But from a statistical standpoint, how common is it?
Yeah, it's a good question. Prostate cancer is actually very common. It's one of the most common cancers that men experience. And one of the important things to know is that even though it's common, there are also a significant portion of people who have more aggressive disease. So not everyone who has prostate cancer will die from prostate cancer, but people who have an inherited cancer risk can sometimes be at the highest risk of dying from prostate cancer. So that's really important to understand, and that's part of our conversation today, and hopefully the listeners can kind of take that home. So average is 1 in 9 men is the average risk. And 4 million men are living with prostate cancer. So it's significant.
Yeah, it certainly affects a lot of people. And I'm glad that you highlighted that there are different levels of this where you can have aggressive forms and more mild forms, because I know that's something that, even though I'm not a cancer genetic counselor, when I'm taking patients' family history, that's certainly something we're talking about. Cancer comes up in almost every family, I would say. So when we're looking at this, and people that are listening that are either healthcare providers or looking at their own family history, what are signs of that hereditary prostate cancer, as opposed to, well, maybe it was more random, which means we don't really know what causes it? Mm-hmm. What should people look out for in terms of those red flags?
Yeah, I think this is such an important question, and I think I spend a lot of time educating patients and also my colleagues as doctors on this. The things that are important to think about, we know that prostate cancer family history is really important, but as I mentioned, all prostate cancer is not the same. So things that are really important to pay attention to would be, how old is the relative when they had their diagnosis? And is there a way to get a sense of how aggressive the disease was? In other words, did they have surgery? Did the urologist feel that it was safe to watch the cancer and not do as much treatment? Did the person get chemotherapy or hormone therapy for their prostate cancer, and did they die from their prostate cancer? Those are things that we kind of want to know about any cancer family history, but also especially important for prostate cancer. And then the other important take-home point is that it's not just a family history of prostate cancer, but there's a relationship between family history of breast cancer and ovarian cancer and pancreatic cancer. And so I myself have had patients who have no family history of prostate cancer, but have really a marked family history of early breast and ovarian cancer. And then they develop a more aggressive prostate cancer in association with, for example, a BRCA2 germline mutation. And so that's something that I think is important to keep in mind is not just the family history of prostate cancer, but also other cancers in the family.
Yeah, I think that's so important to highlight. And another factor to that is sometimes in certain branches of families, we just don't have a lot of people with prostates, and we have more people with ovaries. And so I think that's something we have to be mindful of in terms of, well, maybe we wouldn't see prostate cancer because no one on that branch of the family has prostates. So I think that's exactly right. That limited family structure is something to keep in mind. And usually that's my next question. If there's someone that's had an aggressive prostate cancer, like, okay, anyone on that branch of the family with breast, ovarian, pancreatic, as you're mentioning, I think that's something that a lot of people have to keep in mind that maybe we didn't say years ago. So getting into what we are here to talk about, PROMISE. So can you give us a little context? What is PROMISE? What does it stand for?
Yeah, thanks so much. So PROMISE stands for Prostate Cancer Registry of Outcomes and Germline Mutations. And the goal of the study is really, it's a study in collaboration with many institutions around the country, including my own, University of Washington and Fred Hutch Cancer Center, as well as Johns Hopkins and many other collaborators. And the goal of the study is to, I think, twofold. One is to offer genetic testing or germline genetic testing for patients with prostate cancer, because we're still learning about the role and the importance of germline mutations in the context of prostate cancer. We'll get to sort of the exciting parts about treatment implications. One is access, because not all insurance companies will cover this testing, but we think it's really important. We're also learning as we go. And then the second is for people who have prostate cancer and have germline mutations, we want to understand better what happens with their treatment and how often is it cured, how often, when they get treatment X, does it work really well, does it work less well, how can we learn from that and pay that information forward for relatives and other men who may have those same mutations, because there's definitely some really interesting biology that I think we can take advantage of, and we've borrowed already a lot, or we've learned a lot from the breast and ovarian cancer setting, and so I think bringing that to prostate cancer patients is really exciting.
Yeah, we need so much more data so that we can actually understand what the trends are to be able to apply that to more patients in the future, as you were talking about. In terms of healthcare providers and people listening that maybe know someone that's had prostate cancer or currently have prostate cancer, who is eligible to actually enroll in PROMISE?
Yeah, great question. So we are inviting any individual with prostate cancer or a prostate cancer diagnosis to enroll in the study. And, some people may actually know they already have a mutation. We also especially invite them as well. So anyone with prostate cancer, any stage of prostate cancer is invited.
And does that include people that, say, had prostate cancer 10 years ago and are not currently diagnosed?
Yeah, I think it does. Although if it's really, I think that the value may be a little lower, but, I think certainly if there was a strong family history and someone was closer to their diagnosis, that might be something important to think about. But that would certainly be may be less important in terms of the treatment, but certainly it could be.
Not your target person necessarily,
maybe not
possibly.
But yeah.
Okay, interesting. Yeah. So if people are interested or want to send their patients your way, how does it work in terms of being able to register and starting that process to understand a little bit more about the study?
Yeah, it's pretty easy. I think we've tried to make it as patient friendly as possible, and there's a website, and the website is www.prostatecancerpromise.org, all one word, no punctuation. And people who might be interested can visit the website and read about the study and learn about what's involved. And you can then select the link to register and enroll, provide informed consent, and then you would be patients or persons interested would then be mailed a saliva kit, which is a CLIA certified panel of 30 genes associated with cancer risk. And then those results would take about, somewhere between 4 weeks to come back, 2 to 8 weeks on average. And the results would be issued by phone or by email, depending on the preference. And people who have pathogenic variants would be required to receive their results with a genetic counselor, and that's provided as part of the study.
So regardless of the results, if the panel comes back negative for all pathogenic variants that are included on the panel, so mutations, if that's all negative, they'll still receive a call with that information.
They receive the information by email, and then they have the option to follow up with a counselor, but many people may not feel like that's necessary, but it's certainly an option. So people, so far, some even with negative results have opted to have an appointment with a genetic counselor, but they're not required to, whereas people with pathogenic variants are required to.
Which makes sense. That's how I would want to set up the workflow.
Exactly. That's the only way they would receive their results.
Yeah, that makes sense, to have a genetic counselor walk through, like, okay, what does this actually mean for you? What it means for other family members, possibly. What are some of the most common genes that typically come up in terms of being identified as, oh, there's a pathogenic variant in this gene? I think of BRCA1, 2, PALB2. What else would we add to this list?
Yeah, those are the ones that we've seen to be most enriched in. The answer to your question depends on what stage of prostate cancer it is. So that's part of what we're learning. So we know, at least in the metastatic disease setting, which is the most advanced setting where people may be at risk of dying of prostate cancer, in that population, BRCA2 is overwhelmingly the most commonly observed. It also has treatment implications. BRCA1, less common. Actually, ATM and CHEK2 are also represented, and we're very interested in learning more about PALB2, as you mentioned, and others. And actually, the Lynch syndrome genes are represented as well. MSH2 and MSH6, and the others are to a lesser degree. So part of it is learning about the spectrum beyond the advanced disease setting, and then also looking at treatment response, as I mentioned.
And how often are VUSs identified, so variants of uncertain significance, where we find a genetic change, we say we don't know if this gives someone an elevated risk for cancer or it's just natural human diversity and we think it's probably fine? How often does that come up?
Well, I think it comes up to some frequency. I don't know that we have firm numbers yet in the data, but I do know that we expect to find some, and part of that is what we hope to learn. So variants of uncertain significance are exactly that. We are not certain about what they mean, but when we find them as part of the study in certain genes, and the genes that we think might be most actionable and are already kind of implicated for prostate cancer, for example, BRCA2 or ATM, BRCA1, if the VUSs exist in those genes, then we actually invite patients for follow-up, because part of the hope is that as they get reclassified, we can then give that information back. So that's, and there are also opportunities for enrollment in therapeutic clinical trials. Increasingly, we can talk a little bit more about that. That's really exciting, and something we want to make sure patients are aware of, those opportunities. And then in so doing, we can sometimes reclassify those variants by looking at the tumor, for example. So we look at tumor germline. There'll be opportunities. Now, that's not built into PROMISE, but those are things that we just know from a clinical experience. I actually have had several patients in that situation where their VUSs then are reclassified, and that then is helpful for other individuals who may carry those same variants.
Yeah, because that's the goal, that someday when we have these panels, we're going to get no VUSs, or it's very rare to have a VUS, especially for these genes that are more well known. Obviously, as we learn more about cancer genetics, we're adding more genes to these panels saying, oh, now we know this has a role in certain cancers. But in terms of, for BRCA1, 2, ATM, like for these genes, I would imagine they're the ones that are going to have VUS is very rare before other genes, because we know of these genes and been studying them, especially for BRCA, we've been studying since the early 90s?
Early 90s, that's right, yeah. And I think that that's definitely something we know a lot more about them. We still have more to learn. And one of the truths, unfortunately, is that many of the databases, you probably know this and the audience knows this, but many of the databases that help us classify are largely European ancestry or kind of white patients, and not the diverse populations that we have in the United States aren't necessarily represented equally in those databases. And so, for example, people who are Black may have a higher likelihood of having a VUS, and so getting more data in that regard is also really important to make sure that we give them sort of most useful information back by avoiding, having fewer VUSs, as you said.
Yeah, I'm so glad you mentioned that, because I feel like in a lot of interviews, I'm the one to bring that up. And I'm like, here I go with my soapbox again. Like, we need more people of non-European ancestries to be part of these databases, because as you said, there's a huge disparity. People that have European ancestry are less likely to have a variant where we say, we don't know what this means, versus people of non-European ancestry. And it's just so important. And I hope as part of your study, you're able to include people from a lot of different places in the world so that we can start getting to the bottom of some of that, and just having so much more information there. So we're closing that disparity.
Yeah.
Thank you to all the listeners for nominating us in the podcast awards. You did it. We have officially been nominated. It is year number 6 of being nominated, and hopefully it's going to be our 3rd time winning the Best Science and Medicine Podcast Award. But that's only going to happen if you check your inbox for an email from the Podcast Awards with the subject line, Podcast Awards Final Slate Voting. If you got this email, you are one of the lucky few that were selected to be a voter. So it is imperative that you vote and support the show. I was actually one of the people selected, and I got the email on Monday, August 8th, so maybe you got yours then as well. There's a hyperlink to get you to the voting page. You do have to quickly log back in with the details you used when you nominated us. Once you do, select DNA Today in the Science and Medicine category. Don't forget to select your other favorite podcasts, then hit the Save Nominations button at the bottom. It's that easy. You have until September 10th to do this, but please do it now if you got the email so you don't forget. Very soon, we'll be celebrating a decade of DNA Today. That's right, we released our first episode on September 1st, 2012. It also coincides with our 200th episode. We want to mark these milestones with you on the show. So send in your favorite episode. You can write it, or better yet, record a voice memo sharing your favorite episode and why you enjoy listening to the show. After all, our podcast would not be possible without you loyal listeners. That's why we want to celebrate together. Send in your voice memo or a written message about your favorite episode of DNA Today to info@dnapodcast.com. The deadline is August 27th. Again, send in to info@dnapodcast.com and your voice might be featured. PerkinElmer Genomics is a global leader in genetic testing, focusing on rare diseases, inherited disorders, newborn screening, and hereditary cancer. Testing services support the full continuum of care from preconception and prenatal to neonatal, pediatric, and adult. Testing options include sequencing for targeted genes, multiple genes, the whole exome or genome, and copy number variations. Using a simple saliva or blood sample, PerkinElmer Genomics answers complex genetic questions that can proactively inform patient care and end the diagnostic odyssey for families. Learn more at PerkinElmerGenomics.com. So in terms of these different genes, obviously we've been hinting at treatment, so I want to get into it. What are the current treatment options available for people with prostate cancer before we get into all the nitty gritty of, the genes and variants?
I think if I understand your question, it's, where might this matter? Where might knowing about a mutation matter in the management or the treatment of prostate cancer? And I think we are learning more about it, and it's really exciting. I mean, it's kind of what I built my career on. But first is finding patients who have variants, and then Right now, it's mostly in the really advanced disease setting, the metastatic prostate cancer setting that I was mentioning earlier, people who have had cancer that started in their prostate, then had spread outside the prostate. And this is a situation which is serious, that warrants attention, but the sort of gratifying thing as a medical oncologist is that men are living longer than they ever have before with advanced prostate cancer. So that reflects the fact that our field has advanced and there are more life-prolonging drugs ever than before. And what's really neat is that for people who have BRCA2 mutation, for example, or BRCA1 mutation, or the genes that we're talking about, there are now drugs that are especially, or we have a very good suspicion or high hope that those drugs will be especially effective for people who have cancers that are associated with BRCA1 and BRCA2, for example. And so essentially what that means is knowing about those mutations opens up an additional toolbox beyond what the average patient with prostate cancer already has, which is bigger than it ever has been, but it's even bigger, or there are even more options if people have know about a mutation. And so that's why this is really important for prostate cancer patients. Even though right now it's mostly in the advanced disease setting, and there's 2 FDA-approved drugs, PARP inhibitors, which those who follow breast and ovarian cancer already kind of know are also used in association with BRCA1 and 2, but those are in the toolbox. But the cool thing is also that clinical trials are moving those drugs earlier into earlier disease states, meaning hopefully as we move them earlier, people will continue to live even longer, even if they have cancer. But also, if we move it very early, then maybe more people can be cured. For those who are at risk for prostate cancer, there's also clinical trials now available for screening. So basically saying, can we do as they do in breast cancer and do more attentive screening for cancer if we think there's a higher risk? So all of those things are potentially possible for people once they know they have, they have a mutation. So hopefully, people sort of ascribe to the idea of knowledge is power. So when we know about it, then we can sort of tailor the treatment and tailor the management accordingly.
And that's the beauty of personalized medicine. It's just figuring out, okay, you have a pathogenic variant, a mutation in this specific gene. This is the treatment option that is most efficient for the type of cancer you have and your genetic profile. So it's really exciting to hear how quickly this is changing and things that we learn about in the realm of like breast cancer genetics, how that sometimes can apply to like prostate cancer, especially when we're looking at very similar genes. So I think that's really important information to look at. Are we seeing that this is specific only to genes, like anybody that has a pathogenic variant in BRCA2, this is a good treatment? Or does it get even more specific on that sub level of, if you have this variant in different genes, this is the treatment we're giving you? At what level are we at right now, and is that going to change in the future?
I think it's a great question. I think at the moment, it's actually, in truth, genes on a gene level. So BRCA2, for example, again, being the most common, that we see in the advanced disease setting, we have the most experience with it. The other genes are implicated, so BRCA1, ATM, CHEK2, PALB2, they all occur at lower frequencies than BRCA2, at least in the advanced disease setting, and we're learning about them individually. So until we get more numbers, which we hope to do through the PROMISE study, it's going to be difficult to then narrow it down to the specific variant. But I think in the future that's entirely possible. We will be able to say, this is a variant that is more likely to behave in this way or that way, and it's going to be different gene by gene, and it eventually will be true variant to variant. And an example I would give is I was recently part of a study showing that P53, which is associated with Li-Fraumeni, is actually associated with prostate cancer. But what's really interesting about it is that, as you might imagine, the most profound P53 variants, meaning the ones that affect patients at the earliest ages, or childhood cancers or young adult cancers, those individuals may not live long enough to get prostate cancer.
That's
So
something
what
I've
we
never thought about.
observed-
Wow, yeah.
Yeah, it's kind of cool. So, I mean, it sort of makes sense, right? The people that are at risk for prostate cancer are the ones that may have more sort of hypomorphic or attenuated variants. So they actually live long enough, and then they may actually be at risk for prostate cancer. But if, depending on how you do your analysis, there were actually some historic studies that said, you know, P53 was protective against prostate cancer. But the truth was just that the people weren't living long enough to even be at risk for prostate cancer. So you have to be really careful about how you do those analyses.
Right,
But,
look at the full
but I
picture.
think-
Like, you know, children may
Exactly.
not be developing prostate cancer, and if they're developing other cancers, because P53, that's one of the most serious hereditary cancer conditions in terms of, as you said, like childhood cancers, young adult. But that's really interesting that, you know, we just didn't think about it in that way.
Yeah. So that's an example, going back to your question, of where the variant actually might make a difference, because certain variants are not going to be, you know, as associated with childhood cancers, and may be more associated with prostate because the individuals can live longer, because, you know, we're doing so much better in modern medicine to help people do better to an older age and be at risk for prostate cancer.
Right.
And,
Yeah. And I think
hopefully
it's
manage their prostate cancer.
Yes. And it's obviously so common, as we've been talking about, and as we started our conversation, for people to develop prostate cancer. I've, you know, heard people say, oh, if you live long enough, eventually you're going to develop prostate cancer if you have one. A lot of autopsies show that, oh, actually there is early signs of prostate cancer. Even people that are elderly are like, well, it's growing so slow, I'm not even going to treat it because I'm probably going to die from something else. So I don't want to go through any treatment for this. How true is that? Is that kind of old wives' tale, or is there some truth behind that in terms of just the risk for prostate cancer for lifetime?
Yeah, no, I think it's actually an excellent point, and it is true. So I think it reflects, or the take home is really that we really do need to be tailoring our treatment to the patient. So it is true that as you get older, the risk of prostate cancer goes up, and, you know, you might estimate from autopsies, as you mentioned, that by the age of 80% of men might have prostate cancer, but the majority of those are not life-threatening. Now, that doesn't mean there isn't a proportion that is life-threatening, and so just getting a better picture of what that person's cancer is. And it is absolutely the case that the field is moving towards, in many cases, if we think it's what I call a wimpy prostate cancer, then we just watch it, and that's better overall for the patient, minimizing side effects, minimizing risks of treatment, to watch that patient. But other people are going to have much more aggressive prostate cancer, or be at risk for prostate cancer because of the family history. And those patients need sort of tailored management. Maybe those are the folks we want to watch more carefully. We'd want to screen for PSA, prostate-specific antigen, the blood test, to sort of try to catch the cancer early if we think there's a higher risk. So this is all, you know, as we get more information, we want to empower people together with their healthcare team to kind of tailor things appropriately.
Yeah, that makes sense. And, you know, it's case by case, as we're talking about for a lot of this. And the more pieces of information, the more we can tailor all of this, especially with treatment. I think it's just so exciting, like, where we're headed with this in terms of all the possibilities, and just how we've seen things change so fast too. I think that's just, it's really empowering to hear. And as you said, like, knowledge is power. And I'm so on track with that. I think a lot of listeners would agree with that. Anything else that you would like to leave our audience with today?
No, I mean, I guess I would sort of end by saying, you know, really encouraging, if you know someone with prostate cancer, I think the PROMISE study is really an exciting opportunity to learn more, and learn more together for yourselves and for the future. And then the other thing I would just say is just thinking about cancers and the relationship of breast and ovarian cancer to prostate cancer. And really it's the whole family. So men in families that have BRCA2 don't always know about the importance to their health. And so I guess that would be the other thing that I would like to leave people with, is if you know, if this is counseling, a genetic counseling audience, if you know of men in those families, then really emphasize the importance to them of knowing about these mutations, both for screening as well as for management.
Yeah, and certainly to let family members know as well. so that first degree relatives can be tested and then kind of, cascade after that in terms of testing. Because I think as, genetics people, we're like, all right, well, who else in the family? And I think that's where I'm always going with it.
Right.
Yeah, but it's very exciting for people to be able to learn more about it. prostatecancerpromise.org. We're going to have a link to the show note in the show notes, which is available at dnapodcast.com. And so I think that's great for people to learn more there. And it's really exciting to be able to not only learn more for yourself, but also to contribute to science. I think it's really exciting to be part of clinical studies and be paving the way for future treatments. And just, as we said, we need more data. So people, let's step up. Let's all contribute. So thank you so much, Heather, for coming on. I think this was just really interesting and certainly opened my eyes on a couple things today. I've got to rewire my brain in terms of how I'm thinking about certain conditions here. But thank you so much for teaching me and my audience about PROMISE and prostate cancer.
Oh, you're very welcome. It's a pleasure.
For more information about today's episode, visit dnapodcast.com, where you can also stream all episodes of the show. We encourage your questions, comments, guest pitches, and ideas. Send them all into info@dnapodcast.com. Search DNA Today on Twitter, Instagram, YouTube, Facebook, so you can connect with us there. And a favor, please rate and review the podcast on Apple, Spotify, or wherever you listen. This truly helps us climb the charts and allow more genetic nerds like yourself to find the show. DNA Today is hosted and produced by myself, Keir Deneen. Our social media lead is Corinne Merlino. Our video lead is Amanda Andrioli. Thanks for listening, and join us next time to discover new advances in the world of genetics.
The genes of you and me, the genes of you and me are all made of DNA. We're all made of the same chemical DNA. We're all made